Good morning, everybody. I think we're ready to now start this session. My name's Ishmael Beckford and I'm Chair of Council. Just to let you know, the format today is we're going to have, I believe it's going to be 3 presentations to start with, then a Q&A slot, then a further 4 presentations and then a subsequent Q&A slot. So if everybody through these presentations starts to think of any questions or queries or reflections that you might have, just so we have got questions to get stuck into after each slot. I'd like to invite Christopher Haller up first, who's going to be talking about his, I think that's probably, qualitative study. Thank you.
Hello, my name's Chris Haller. I'm an advanced practice physiotherapist and a PhD student. In this talk, I'm going to share the findings and clinical implications from our study, which explored the communication of diagnostic uncertainty and safety netting information to patients with low back pain. Diagnostic uncertainty has been defined within the literature as a subjective perception of our inability to accurately explain the patient's health problem. This is inherent within musculoskeletal practice due to the complexity and multifaceted nature of the musculoskeletal pain experience. One strategy to help us manage this diagnostic uncertainty in collaboration with the patient is safety netting. Safety netting information is the information that we share with patients to help them identify the need to seek further help if their condition persists or worsens. This involves communicating diagnostic uncertainty, the likely time frame for their condition, and advice about when, why, or how they could seek further help. Therefore, safety netting is used within a clinical reasoning framework to help manage uncertainty or risk associated with their condition persisting or worsening. For example, the National Cord Requirement Care Pathway in England recommends safety netting advice for patients who may be at risk of developing Corde-Quine syndrome. This aims to empower the patient to recognise the symptoms and to seek emergency medical review if they develop. This is important because we know the importance of emergency neurosurgical intervention for patients developing Corde-Quine syndrome to reduce the risk of permanent and life-changing impairments such as bowel and bladder incontinence. So let's explore some of the literature. A literature review in 2019 surprisingly found a lack of empirical research for safety netting. Most of the studies have focused on general practice or emergency out-of-hours care contexts. A seminal study by Edwards and colleagues in 2019 developed a safety netting coding tool to analyse video and audio recorded GP consultations in the United Kingdom. They found a variability in practice. From a musculoskeletal care context, seminal work by Sue Greenhouse and colleagues found inadequacies in the communication of safety netting related information to patients with Corde-Quine syndrome. This led the authors to develop the Corde-Quine warning card, as you can see on screen now, which aims to facilitate the safety netting process. However, there remains a lack of understanding about how safety netting information is communicated in practice. Therefore, we conducted a study aiming to explore how physiotherapists are communicating safety netting information to patients with lower back pain. We did this through a secondary analysis of 79 audio recorded consultations. These took part in an outpatient physiotherapy department in England. This involved 12 physiotherapists with a range of clinical experience and 41 patients with lower back pain with and without associated leg symptoms. we used the safety net encoding tool developed by Edwards and colleagues that we discussed on the previous slide to code and categorize safety net and related information in terms of evidence of diagnostic uncertainty, discussions around the time frame for the patient's condition, and any advice about when, why, and how they should seek further help. So we'll discuss these findings now. There was evidence of diagnostic uncertainty language evident within 67% of the consultations. These were mostly indirect statements of diagnostic uncertainty, where the physiotherapist might say things like, "I think this is," or "it could be." This is in contrast to explicit statements of diagnostic uncertainty, where a clinician might say, "I'm not sure what's happening here, it could be X or Y." Here's an example of an indirect statement of uncertainty. The physiotherapist said, "I think it's muscular, but I think there's a bit of stiffness in this joint as well. I think that's probably, maybe, possibly what may have been the underlying cause in the first place." So we don't know what the patient's perspective of this particular language was, and that will be a focus of my PhD research. But what this does show is the prevalence of the diagnostic uncertainty language that we were seeing throughout the consultations. There were no examples of physiotherapists providing specific information regarding the patient's condition, expected condition time frame. There were some generic prognostic statements given through the consultation, such as this. The physiotherapist said, "Sometimes nerves take quite a while to settle down. I think it should fully resolve." The third category is safety net and advice. So this is information about when, why, and how to seek further help. From our sample of 41 patients, 8 received, that's 20%, received safety net and advice. Only one of these patients received safety net and advice in their initial consultation. Some patients received safety net and advice on more than one occasion, and therefore there was 19 episodes of safety net and advice given in total. From these 19 episodes of safety net and advice given, 58% did not include specific signs and symptoms that the patient should monitor for, and 16% did not include specific information about action the patient should take if their condition was to worsen. Here's an example of a safety net and statement. The physiotherapist said, "In that 6 weeks, if you find it's getting worse, despite you doing the exercise, it's just not getting any better, then phone up and make another appointment." So this quote illustrates how many examples were quite generic about the symptoms persisting or worsening, rather than giving specific information about signs and symptoms the patient can monitor for. We identified potential missed opportunities for safety net and information in around 24% of consultations. This mostly related to the patient's associated leg symptoms, such as numbness or weakness, but also related to potential more serious pathology, such as cord equina syndrome, or opportunities to support the patient to self-manage. So what can we learn from this? The qualitative research tells us the importance of being open and honest with patients about what we know and what we don't know in terms of their diagnosis and prognosis. This involves discussing the complexity and multifaceted nature of the musculoskeletal pain experience, and that includes discussing the best available evidence. It also tells us the importance of working in partnership with the patient to navigate this uncertainty. And we can do this through asking open questions, active listening, and exploring and managing the patient's concerns and expectations. When delivering safety net and advice, this should be clear using simple language. We should consider providing more specific signs and symptoms the patient can monitor for, and this should be personalised to the patient's needs. Consider using written information or signposting to other resources, such as a cord equina warning card, so the patients don't need to memorise all of the information that we give them in the consultation. To help you evaluate and develop your practice, you could consider, with the patient's consent, audio recording your consultations, and you could use the safety net encoding tool that we used to self-evaluate your practice. Alternatively, if a colleague could observe you in practice, they can use something like the consultation assessment form available on the Bristol website to give you feedback. For further information, please do check out our full paper via this QR code. And through my PhD, the focus is on further exploring and developing safety netting communication in musculoskeletal physiotherapy. So watch this space. Thank you very much.
Thank you. So I think we're going to go to the next speaker, who is Jack Messenger. What role can physiotherapists play in enhancing patient adherence to physiotherapy, back pain in adults? And I believe that this is a pre-recorded slot.
Hi, I did a scope and review on what role can physiotherapists play in enhancing patient adherence to physiotherapy treatment of low back pain in adults. The objective was to summarise and map the recent literature and identify disparities and gaps for future research. 80% of adults worldwide will experience low back pain at least once in their lifetime, and with high reoccurrence rates, people are likely to suffer low back pain repeatedly or develop chronic symptoms. The Health and Safety Wellbeing Group is a subgroup of the NHS Staff Council who reported 68,000 work-related cases of MSK disorders, constituting 22% of all ill health in health and social sector. The UK Health and Safety Executive in 2020 to 2021 reported 39% of all work-related MSK disorders attributed to low back pain. As well as being physically, mentally and socially debilitating, it also incurs societal costs, including higher healthcare utilisation, expenditure and work absenteeism. In the UK, the prevalence of low back pain is expected to rise due to an ageing population and reduced accessibility to physiotherapy services resulting from the COVID-19 pandemic and healthcare backlog. This poses a significant public health problem, being a leading cause of ongoing disability in adults with an escalating trend. To address this problem, physiotherapists prescribe home-based exercise programs alongside clinical appointments. However, non-adherence is high, which negatively affects treatment duration, effectiveness, efficiency, and therapeutic alliance, which also contributes to increasing waiting times, cost of care, and therefore expected benefits aren't delivered. So the methodology followed the Joanna Briggs Institute Guidance Framework and the PRISMA SCR checklist. Spider tool was used to define eligibility criteria. There are the search terms and the databases searched. There were 9 full peer-reviewed articles in English published between January 2018 and January 2023 after inclusion-exclusion criteria was applied. Literature was not systematically appraised to advocate inclusivity of data and novel insights, although it's acknowledged that lower quality methodologies and biases may be included. Data, quotes, and pertinent points from within the articles, results, and authors' discussions were synthesized using a narrative synthesis and amalgamated into common language under 3 key themes. These were the role of an educator, which included improving patient awareness, knowledge and efficacy of self-management, a motivational coach where the physiotherapist provided motivation, use shared decision-making to prescribe and demonstrate specific and simple patient-centric exercises, and a strategist who understands and addresses patient-centric barriers, utilising behavioural change techniques and technological rehabilitation to enhance adherence. For the results, there were 9 studies comprised of 5,173 participants with a mean age of 47 years, with a 65% female and 35% male gender split. Most of the reported low back pain was classified as chronic, such as greater than 3 months, and the results were from studies were from Australia, USA, and higher income countries in Europe. Of the 5 quantitative studies, 3 were observational, 1 was a case study, and 1 was a randomized controlled trial. Of the 4 mixed methods, 2 were qualitative embedded within RCTs, 1 was an observational with survey, and the other was a questionnaire interview. Some quotes from the included studies demonstrate the multidimensional role of the physiotherapist. So the blue is an educator, the orange is the motivational coaching, and purple, the bottom one, is demonstrating behavioural change techniques, specifically CBT through reflection, and the one on the right demonstrates technological rehabilitation. There are many more I could include, but I don't have time. The synthesis outlines 3 key themes which corresponds to the multidimensional role of the physiotherapist and the physiotherapist can play in enhancing adherence to physiotherapy treatment of adults with low back pain. There's promising preliminary evidence which has been identified relating to physiotherapists, especially as a strategist to enhance adherence, specifically behavioural change techniques such as CBT and motivational interviewing, and technological rehabilitation strategies, which all warrant future research. However, defining a single effective strategy to facilitate patient adherence was challenging due to the multidimensional nature of adherence and the variety of measures used. Generally speaking, enhancing adherence through improving and extending the therapeutic alliance on multi-levels and facets often in combination with exercise-based strategies, is the way to go. However, there are many disparities with the concept of adherence, such as definitions, interchangeable terminology, and no agreed gold standard for measures. This review therefore found a lack of available evidence to draw definitive conclusions. Therefore, the findings recommend that more robust literature is required, such as randomized controlled trials using comparable measures to further understand the topic and address disparities which may limit future adherence studies. Thank you.
Thank you to Jack. Next up, we have got Shemaine Murta covering a delay in MSK physio. A low number of therapy sessions have a negative impact on therapy.
Okay. Hi everyone, I'm Dr. Shemaine Murta. I'm a Senior Research Fellow at Keele University and I'm the lead researcher for the Data for Impact project. So the Data for Impact project at Keele is funded by the Physio First and the Private Practitioners Education Foundation, and it's a national research project. The research that I'm going to talk about today comes from that project, and we're looking at an impact, how a delayed to treatment can impact the treatment outcomes, and how potentially the number of treatment sessions can also impact those outcomes. Okay, so we know that there often are delays to treatment. Many patients decide to take a wait and see approach to see whether their symptoms get better by themselves before accessing treatment. We also know that there are limitations to resources and sometimes inappropriate referrals that cause delays. Yet we know that there are also the treatment outcomes sometimes are hindered due to that delay. So our research question was to look at the impact of that delay and evaluate that, and looking at how the delay between experiencing those symptoms and accessing treatment, and how those number of treatments can really impact your overall treatment outcomes. Within this, we looked at various different subgroups. So we looked at how age, sex, the pain at baseline, and the previous condition of the patient affected those relationships. So as I said before, this is part of a national ongoing data collection that is in private practice. What we do is we collect from private practice. It's a standardised data collection, and physiotherapists throughout the UK are contributing to this national data bank, and we are able to pull from this and draw this research question. So for this study, we had 3 different outcome measures. We looked at pain, and we looked at on discharge whether they had an acceptable level of pain at discharge versus an unacceptable level of pain. We looked at functionality, so we used the patient-specific functional scale and this was activities identified by the patient to see whether they made a significant improvement on that scale, and we compared those that didn't make a significant improvement. And then we looked at the goals of the patient and whether they were fully reaching their goals. And these were goals that were set between the patient and the practitioner, and they were agreed on the initial first treatment. Oh, pressing the wrong button, sorry. So the findings were really interesting. So firstly, looking at the duration of symptoms and the wait time, and we found that there was no difference between those that waited up to 2 weeks before accessing treatment to those in their outcomes compared to those that waited up to a week. However, we did find across all 3 outcomes that there was significant less favourable outcomes in those that waited between 3 and 6 weeks compared to those that waited up to 2 weeks before accessing treatment. And again, we found less favourable outcomes for those that waited 6 weeks or more compared to those that waited between 3 and 6 weeks. And these were, just to emphasise, these were across the pain, functionality and goals. Concerning the number of treatments, again, so we found that those patients that accessed just 1 treatment session were significantly less likely to have favourable outcomes across all 3 outcomes we measured than those that received 2 or more treatments. We found that those patients that accessed 4 treatments and above had significantly better outcomes than those that accessed fewer than 4 treatments. But really interestingly, we found that there was no difference between the patients that accessed 5 or more treatments compared to 4 treatments. And that suggested maybe an optimal number of 4, and then there's no additional benefit effects in terms of better outcomes across pain, functionality and goals. When we looked at the subgroup analysis, there were marginal but significant differences. So for age, we found there were slightly less favourable outcomes for older individuals. We found that a slightly significant difference for males compared to females in achieving these outcomes. For those individuals that had previous episodes in the condition that they presented, they were slightly less likely to achieve their goals than those that had no history of the condition, but they were no less likely to achieve those good pain scores and achieve a significant change in functionality. And finally, we looked at the pain at baseline to see those that come in with a severe level of pain. They were slightly less likely to achieve those favourable outcomes compared to those that didn't, but they were still achieving those outcomes. So, in summary, what we take from this is time is of the essence, and we can really encourage patients to potentially not wait and see, maybe wait up to 2 weeks, but do access treatment sooner rather than later, and you are more likely to see the favourable outcomes. The finding in relation to the optimal number of 4 treatment sessions was really interesting, and it can help set patient expectations and planning for treatment. I would like to emphasise that these results are across all MSK conditions, so it'd be really interesting to really zone down on different conditions and see how that varies. And really interesting that although there were significant difference between the subgroups, they were marginal. And so we can see an improvement for all, and regardless of your previous condition, your age or gender or any other factors, that everyone experienced favourable outcomes, but the main finding was the sooner the better. So the full findings are published in that paper, and you can access it by the QR code, and it talks about the patient demographics and the conditions presented. And I'd just like to signpost you, if the Physio First project is an ongoing project, and we are currently collecting data from all private physio. So if you are a private physiotherapist and you want to take part in this ongoing data collection at Keele University, then do get in contact. Chair of PPF is in the audience, and or contact myself, and yeah, be really great. Thank you so much for listening. Okay.
Thank you, Shimon. Should we take a seat up here? So we've now got 10 or 15 minutes or so for questions. So does anyone want to start us off with a question?
Thank you very much. They were great presentations. It was a question for you, Shimon. It was around your numbers. When you talked about 4 treatments, was that 1 initial consultation and 3 follow-up appointments? And did you see a lot of treatment happening in the initial consultation? Thank you.
Yeah. Is that on, actually? Is that on? I
Yeah.
don't know. Yeah, okay. Yeah, it did include the initial treatment session, and predominantly there were, looking at our data, it does look like that initial consultation is treatment as well. But it's really exciting because we do have that data set, and we can start to explore what that initial treatment session looks like in private physio, and how patients can benefit, because of course there will be particular conditions that may benefit from that initial early advice and reassurance that the consultation and the treatment can provide in that session. So, thanks.
Thank you. Great presentations, guys. Quick question to Christopher. I've always associated physiotherapists with having fantastic communication skills, and with your study, what do you feel were the barriers to effective safety netting with the physiotherapists, and were variables such as the physiotherapist's own experience in banding or the complexity of the patients considered during your study?
Yeah, it's a great question. I think inherently within physiotherapy, we focus a lot on developing lots of our skills around treatment modalities, etc., and perhaps don't put as much focus and emphasis needed on communication as we should. I think it's going to be really interesting in terms of my subsequent kind of studies as part of the PhD and observational work, where we'll have opportunities to really explore that with patients and physiotherapists through further observations and interviews, so we could perhaps get, you know, a little bit more depth to that answer. And then what was the second part of your question, sorry?
I was just looking at the experience of the physiotherapists who are
yeah,
taking part in
yeah.
it, and also the complexity of the patients.
Yeah, so the experience was interesting because we had a range of clinical experience in terms of time in the musculoskeletal speciality, from weeks to years, and bandings from 5 to 8. And there was 12 clinicians that took part in the initial studies, which we did a secondary analysis from. And it was definitely a question we had, and I tried to explore that. I couldn't necessarily find a pattern from the data set to suggest, you know, whether it's more likely to be, you know, the language that we were seeing was more likely to be in different bandings. I couldn't draw any strong conclusions from that perspective. In terms of the complexity of the problem, I think, again, there wasn't that level of analysis, I guess. We were using the safety net encoding tool, which really just focused in on the words used, and we added in the extra part around trying to identify potential missed opportunities, and that was based on our reasoning and our knowledge of the evidence-based, and drawing on different things like the international framework for managing serious spinal pathology, for example, which recommends safety netting advice for certain problems. So we were drawing on that to identify where safety netting may have been missed or been beneficial. But yeah, again, some really important questions to ask in our future studies.
Hi, my name is Umar Sheikh. Just a question regarding the number of sessions. You did mention that this study was, if I didn't heard it wrong, was done in a private clinic settings, yeah? So in NHS, we see different patient population as compared to the amount of waiting times they have gone through to be referred to our clinics. So do you think the results from this study is comparable to the population we see in our clinics?
Yeah, I think that's a really good question. And actually, it's really pertinent to the current project, because we're actually aligning to the MSK national audit within Keele University. So long term, over the next 2 years, what we're doing is aligning that and seeing how, because of course, within private and NHS, patients move in between. They access private, they sometimes are on the waiting list and they go and see a private clinician, or vice versa. So we're aligning the two data sets and the way we measure that data so we can understand, and we are going to use the NHS number within our data set so we can really understand and generalize our results to understand how the waiting time within the NHS can potentially impact those treatment outcomes. But we're really excited about that development to our project, because it's going to provide a much fuller picture of MSK physiotherapy in the UK, and of which private physio is a big component of that. So yeah, great question.
There's another question here, and then there's two at the front.
Was that?
I think he's put his hands gone down. I think.
Hi, great presentations, really enjoyed it. And then it's similar, Shemaine, to the question you just answered. Do you think if you extrapolated that evidential basis for early intervention to people with symptoms that had been present for 3 years, you'd get the same compelling argument for MSK?
Oh, so if they had, their previous conditions had been 3 years,
Yeah.
and then they, I guess in this study, we looked at previous conditions, but we didn't look at the severity of those previous conditions. So we just knew whether they had no condition, one previous episode, or many. And it was those individuals had many previous episodes, but of course there is a huge category in there. And we're actually increasing and updating our data collection to look at potentially who those patients are that have those really chronic conditions and how that influences the number of treatments required and that wait time, how that wait time really potentially negatively impacts that. So moving forward, at the moment, we wouldn't be able to answer that question because we don't have the depth of data for the previous episodes. But moving forward with the developments at Keele University with this wider research project, that we're really excited that we will be able to get that. And in terms of, so obviously I really pushed the data for impact joining that, but in terms of for everyone working in the NHS, I know certain trusts have onboarded to the MSK national audit at Keele, but it is a really great way. The more trusts that do onboard onto that, the more that we can evidence what is happening in physiotherapy and use data to understand and improve treatment outcomes for patients. So Roanna Burgess and Jonathan Hill at Keele will signpost you to getting involved in that. And then, of course, through the private side, PPF, Physio First, or myself. So, yeah, we're really excited to be able to delve into that, to really understand the influences of that for patients, particularly with chronic conditions.
Thank you for the talks, both. Shemaine, I think you've kind of answered some of that question, but a reflection and then a question at the end. You were linking your data with Rowan and Jonathan's data set as you were talking about. I'm assuming this large big data will then lend itself to AI and will start to make associations like this many treatment sessions, this duration of wait. Is there enough granularity going in that we can start to look at causal links as opposed to associations? Because that will then perhaps start to answer the questions about what conditions at what part in the pathway can we reap the benefits of this data?
Yeah, so there's always a bit of a push and pull with the granularity with the data collection and engaging practitioners to enter the data, because time I don't want to use time is of the essence for practitioners as well when it comes to entering data. But as we develop, and we are at the moment developing our data collection, it becomes easier and more efficient to enter data. And over the next 6 months to a year, we're updating and looking at, and we're having stakeholder agreement to what are those data points that we really need to collect to really understand and evidence, and then make changes within private physio and beyond, and within the NHS. So we're looking to have that, the balance of that granularity and the onboarding with the trust to ensure that actually everyone is collecting data almost the same but slightly differently between trusts and between private practice, but to bring everyone together so we have that picture and we can improve those outcomes, but not just in research in an RCT, but with real life data. So it's a big move forward, and we're really happy that PPF have funded it over the next 2 years. So we're hoping, and with that data bank, we have educationalists that are, we're encouraging access to that data points for researchers to be able to use and understand on key areas that they're interested in as well. So we encourage engagement with the team as well.
Thank you. I think we've got time for one more very quick question and quick answer.
Hi, Shemaine.
Hi.
It was a great presentation. Thank you. Just a quick question then. I know from the Data for Impact project that I've participated in myself that the drop-down menu that looks at modalities, certainly from private practitioners, over 85 or 90%, the first one is education and advice. So that always, obviously this is anecdotally me speaking, but that's always the first thing that the practitioners tick. So I would suggest that treatment does occur in the vast majority of cases in the first session. But do you have any plans to look into the data further and look at what treatment modalities made up the four?
Oh, made up the 4 sessions. So we published a paper recently and looking at low back pain and the combination of treatments. And I think that was a really interesting paper, because quite often we look at what is provided and how does it align with the national guidelines, but not really understanding the combination that as a practitioner you select to think, okay, they need this, but they also need that reassurance and they need that guideline. And actually that is, sometimes it's outside of the NICE guidelines, but sometimes you feel that would be beneficial to that patient and making that decision. And looking at the combination of treatments provided, and we have that real life data to do that. And the next step along from that is looking at the combination of treatments and the outcomes associated with that, which we can now start to do. And we're not only using patient-reported outcome measures that are collected within clinic, but we're extending the data collection so we can reach out to patients and get those PROMs and PREMs validated externally as well, so independently from clinical data within the clinic. So so we do collect at the moment. The MSK national audit is predominantly patient reported with some clinical data set, whereas we are predominantly clinical data set, and we are extending to collect more PROM and PREM directly from the patient data sets. But as we move forward, we're going to align these two data collections and extend both, but still keeping it in with the remit, so practitioners are able to collect this data, because that's an important part, that they're able to fit it into their practice. And we work with physio first, but we know there's a huge demand to kind of embed this into practice, and you're already potentially collecting paper notes and collecting data via practice management software, and trying to work with these companies so we can embed our data collection into these PMS companies, so we can easily take that data collection and use it as part of a big national data bank, and at the same time feeding it back to practitioners, so we're able to answer these larger research questions, but practitioners are also able to use that data to understand what they're providing to their patients and what their treatment outcomes look like against national data sets. So it's quite an exciting project, and we're focusing on both sides, so giving that data back, but also using it for research purposes. So
Great, thank you.
Great, thank you. Thank you to all of our speakers, and thank you for answering those questions. So next up, we have got Chinonso Igwezi Chidobe talking about the role of posture in spinal pain, perceptions and practices of clinicians and academics in 6 continents.
Hi everyone, I'm Dr. Chinonso Igwezi Chidobe from the University of Bradford. So I'm going to present a study we completed to find out the perceptions and practices of clinicians and academics in 6 continents regarding the role of posture in spinal pain. For many years, we've been told about supposedly what we call the correct posture, where we maintain a neutral spine with cervical lordosis, thoracic kyphosis, and lumbar lordosis, and that we're supposed to maintain this neutral spine in sitting, standing, walking, and lifting. And obviously, people tend to use that as a strategy to reduce the burden of spinal pain, particularly back and neck pain. But then, what does the evidence say? So, evidence from observational studies show contradicting results at best. So, in some studies, we have positive associations between posture and spinal pain. In some others, there is no associations at all between posture and the onset of spinal pain. In the studies where we do have positive associations, there is unclear dose-response relationships. For instance, how much of trunk flexion is bad, how much of trunk twisting is bad. And for those studies as well, there is unclear causal associations. And for the studies we've completed, particularly in low and middle income countries, we found that different postures have been identified as aggravating in different people. And for some other people, posture has no influence at all. The evidence from clinical trials have shown that ergonomic interventions really have not been able to prevent the first onset of spinal pain. And among patients that already have existing spinal pain, complex interventions that have postural components have failed to link improvements in clinical outcomes to changes in posture. So currently, it appears that there are 3 schools of thought: those who think that posture is really, really important in spinal pain, and there are specific good and bad postures; those that think that posture is irrelevant and should be ignored; and then those that think that posture might be important, but not for everyone. So overall, what we are seeing is that there might be no universal good postures among all people. Of course, it might be important for some people and not for others. And so clinical recommendations, I think, is emphasizing the need for personalized care and self-management to target personal aggravating factors in different patients. And of course, the importance of healthy lifestyle as very key. And so we went on to investigate to what extent spinal pain practitioners and academics are adhering to what the evidence is saying in relation to their perceptions and practices regarding the role of posture in patients with spinal pain. So this was an online cross-sectional study. The participants were working in 9 countries across 6 continents. We used convenience sampling, so we aimed to recruit people from the 17th International Forum for Back and Neck Pain Research. So the questions we asked about perceptions, asked participants if they felt posture should be assessed, and postural hygiene, whether they felt posture and postural hygiene should be assessed or measured. And then in terms of practice, we asked participants if they measured or assessed posture and postural hygiene in practice. We also asked questions regarding the knowledge of standardized ways of assessing posture and postural hygiene. We also asked questions whether they knew of any outcome measure for measuring postural hygiene. So because the online cross-sectional study combined a mix of open-ended questions and closed-ended questions, we used thematic analysis to analyze the qualitative data, and then we summarize the quantitative data using frequencies and percentages, and then we used Fisher's exact test to look for associations between the quantitative variables. And so majority of the people that provided data for this study were working in Nigeria, followed by those in Australia, then Brazil, USA, India, UK, Ghana, Colombia, and Iran. Majority of the participants were physiotherapists, followed by medical doctors, and majority were specialized in musculoskeletal or orthopedics, followed by those in general practice. So we're able to recruit just 45 participants from the 17th International Forum for Back and Neck Pain Research. And so we invited additional participants from one university and one teaching hospital from the countries where those participants came from. And so we're able to recruit additional 39 participants, making a total of 84 participants that provided data for this study. So in terms of perceptions, the open-ended questions that were asked, people explained posture and postural hygiene in terms of specific good postures and ergonomics. Majority of the people felt that posture should be assessed and should be measured. Majority of the people felt that postural hygiene should also be assessed, but about slightly more than half felt that postural hygiene should be measured, but majority of the participants felt that posture is a risk factor for all spinal pain. In terms of practices, less than, of course, you see that there's a little bit of drop here. So slightly more than half assessed posture in practice, but very few measured it. Less than half assessed postural hygiene, but very few measured it. The major reason for assessing posture or postural hygiene was for diagnosis, treatment, or prevention. Majority of the participants educated their patients on postural hygiene, and the most prevalent method of assessment was observation, and majority of the participants did not know how to measure posture or postural hygiene, and so did not measure these. In terms of knowledge of outcome tools, majority of the participants did not know any standardized method for assessing posture or postural hygiene. Majority did not know any outcome measure for measuring posture or postural hygiene. So we found really interesting associations. So there was association between perceptions and practice. So those who felt that posture and postural hygiene, for instance, should be assessed were more likely to assess it in practice. We also found positive associations between knowledge of standardized way of assessing posture and postural hygiene and practice. So those who knew a standardized way of assessing posture are more likely to assess it in practice. But these associations was not found in terms of measurement. So people felt that these posture and postural hygiene shouldn't really be measured. They can be assessed but not measured. Majority of the findings were similar between low and middle income countries and high income countries. However, a few differences were observed. So more people in low and middle income countries believe that posture should be assessed and assessed postural hygiene in practice. In contrast, more people in high income countries had knowledge of a standardized way of assessing posture. There were some differences between clinicians and academics. More clinicians believed that posture should be assessed and assessed it in practice. Measured posture in practice, believed that postural hygiene should be assessed and assessed it in practice, and measured postural hygiene in practice. In contrast, more academics than clinicians had knowledge of a standardized method for assessing posture. We also found associations between experience and practice. So more experienced participants had knowledge of a standardized method for assessing posture. More physiotherapists assessed posture in practice, knew a standardized method for assessing posture and postural hygiene as well. So we are aware of the limitations of this study in that the results cannot be generalized because of the limitations of the sampling, convenience sampling that we used. But what we do know from the results of this study is that the practice of emphasizing specific good posture is still predominant in spinal pain management in many countries. And it might be more prevalent among clinicians, among physiotherapists, and among people practicing in low and middle income countries. This contradicts research evidence, and there is also some research suggesting that it can encourage negative spinal pain beliefs and fear avoidance in patients, which are very strong predictors of disability. Another thing that the results might be suggesting is that the lack of standardized assessment or use of outcome tools might be contributing to the uncertainty about the role of posture in spinal pain. So I want to thank the CSP's Widening Participation Award for funding me to this conference and the Nature Research Award for funding the data collection for this study. Thank you.
Thank you. So next up we have got Suzanne McElroy, who is going to be doing a platform presentation on prehabilitation, perioperative rehabilitation, and post-operative rehabilitation for patients undergoing lumbar surgery, a survey of physiotherapy practice in the United Kingdom.
Thank you very much. Sorry about the long title. My name is Susie McElroy. I'm a consultant physio at King's College Hospital and a PhD student at King's College London, and I'm supported by a training fellowship from the Dunhill Medical Trust. And what I'd like to talk to you today about is a national survey me and my colleagues conducted exploring rehabilitative practices or practices for rehabilitation for patients undergoing elective spinal surgery. So the three most common types of elective lumbar surgery are microdiscectomy, laminectomy, and single-level fusion. And over 40,000 of these are performed in the UK each year. And guidelines recommend that patients undergoing surgery for these conditions receive rehabilitation. But the current provision is unknown. So there are different phases of rehabilitation, and I just want to provide the definition of what I'm going to be referring to within this presentation. So prehabilitation occurs after a patient has been listed for surgery and before they receive their surgery. It is aimed to augment the functional capacity to help them prepare for their surgery in the post-operative phase and to improve post-surgical outcomes. And frequently it involves exercise, nutrition, and psychological well-being. Perioperative rehabilitation occurs whilst the patient is in the hospital for their procedure. And post-operative rehabilitation is provided as an outpatient after their operation. So what did we do? Between April and July last year, we conducted a UK-wide online survey. Questions inquired about the aims, content, and delivery of the rehabilitation, and filter questions were used to direct the respondents to the areas they worked in and the different surgical techniques, procedures, and patients they treated. So we had 360 responses over 113 different organisations. 70% were from England and 10% each from Scotland, Wales and Northern Ireland. And I'd like to discuss with you some of the key findings from the survey and finish with some of our recommendations based on these results. So the first thing is that there was no clear observable difference between the responses for the 3 different surgical techniques. And this is perhaps surprising because generally the patients that undergo the different techniques, they have different indications and the surgeries are different. For example, microdiscectomies are often performed with a younger patient with a disc prolapse and a lumbar radiculopathy, while a laminectomy is often done on an older patient due to lumbar spinal stenosis and neurogenic claudication and walking disability. And then fusion surgeries are normally more invasive and require a longer hospital stay. So if we look at provision, so prehabilitation was the least routinely provided of all the different phases, where perioperative rehabilitation was the most routinely provided. In addition, respondents reported that perioperative rehabilitation and postoperative rehabilitation was provided under certain circumstances. For example, if there's a new neurological deficit or if there's difficulty mobilizing postoperatively. In addition, it was often the inpatient's responsibility to refer a patient for their outpatient rehabilitation. And so we wonder, if not everybody is being seen as an inpatient, could this be potentially an explanation why access to postoperative rehabilitation is also low? So we maybe need to consider some of the pathways there. So this slide, I recognise, is very difficult to interpret. What it's really showing is the number of sessions of rehabilitation provided. And what you're going to see really from this, and what I want you to take from it, is that there is a complete spread there, big variation. But most people received 4 sessions or fewer, and perioperative rehabilitation, they normally received 1 to 2 appointments. So if we look a bit more closely at prehabilitation, so the main aim reported was to educate patients on their care processes, and 25% of people also reported that it was for optimization of the psychological and physical well-being to aid their recovery. Yet only 50% of people reported that they provided the patient with a physical examination, and even fewer, just 10%, reported they provided patients with specific exercises. So, and we also saw that the timing of when they provided this prehabilitation really varied, with in fact 18% of the respondents saying it was provided before they were listed for surgery as part of their conservative care. So this led us to conclude that there's a huge uncertainty or a lack of understanding about what prehabilitation actually is, and we argue that solely education or physiotherapy provided as part of their conservative care before they're listed for surgery is not prehabilitation. So if we look at perioperative rehabilitation, this was consistently aimed at educating patients about their condition and expediting a safe discharge home. And the interventions provided, which is on this slide, reflected that. About 2/3 of respondents said that they provided participants with specific lumbar exercises, and the majority of these were about lumbar range of movement and core stability exercises. With postoperative rehabilitation, the main aim almost consistently was return to function. And then also 50% reported that improvement in strength and conditioning was the aim of postoperative rehabilitation, and there were multiple and varied interventions utilised. Outcome measure. This may or may not come as a surprise. We saw very low level use of outcome measures. Self-rated pain with the numerical rating scale and back-related disability questionnaires were the most frequently reported, but there was a really big variation. So we wonder, should there be a core data set that could be used across the phases of rehabilitation and along the surgical pathway? And lastly, I just want to talk about restrictions. So, again, there were no clear observable differences between what was being reported about postoperative restrictions between the 3 surgical techniques. 38% of respondents reported they didn't advise their patients on any restrictions. So what did the other 60-odd% report? Well, This slide shows the type of restrictions and the proportion of the respondents that advised about them. I appreciate it's a little difficult there, busy, but the most frequently reported restriction was regards to lifting. And there's a kettle there, and that's because kettle featured very heavily in the respondents' vocabulary. We had responses regarding they can lift half a kettle for 2 weeks, or half a kettle for 6 weeks, or maybe a full kettle for 12 weeks until they're reviewed by a surgeon. We also saw a bit of variation between back movement. So some encouraged this early, right from the beginning. Others said they could move early, but only if they engaged and braced their abdominal muscles. And others recommended avoiding bending and twisting for 6 weeks up to 4 months post-surgery. Furthermore, we asked if people were provided with written instructions about any restrictions or return to activities. And 65% of respondents said, yes, that was provided to the patient. That means 35% of patients potentially are not receiving any clear guidance about or written instructions that they can refer to about restrictions or when they can return to activities. And this is a problem because inconsistent and unclear advice can increase patient anxiety, fear avoidant behavior, and raises the risk of poor surgical outcomes. And all of this may be due reflecting the fact that there's a very low evidence base for what restrictions should be after surgery. And so we really think that further research is required on the impact of restrictions, and clear guidance is required to promote that consistency in care and improve patient outcomes. So our survey demonstrated there's a great deal of variety in the provision and practices of rehabilitation. What we're unclear about is the variation in practice reflective of autonomous practitioners providing multimodal care? Or is it a lack of clear evidence and lack of clear guidelines to help inform practice? And our findings demonstrate that actually access and practices to rehabilitation has not really changed in the last 20 years from when some of the last surveys were conducted. So our recommendations are, we require research on what optimum rehabilitation should be. We recommend research on what restrictions, if any, there should be for patients. We recommend a core data set to follow the patient along their pathway. We recommend these are supported by comprehensive guidelines to support the rehabilitation profession and patients, with careful attention to implementation and adherence of these guidelines. Thank you.
Thank you, Suzanne. Next up, we have got Jonathan Price, who is going to be presenting on the co-development of the EPIC neck exercise program for people with chronic, non-specific neck pain to optimize outcomes and maximize long-term engagement.
Hello everyone, so my name is John. I'm a PhD student at the University of Birmingham and an NIHR clinical doctoral fellow, and I also work clinically at Birmingham Community Healthcare. And I want to talk to you today about some of our work aiming to improve exercise for people with chronic neck pain. There we go. So we know neck pain is a leading cause of disability worldwide, and although clinical guidelines recommend exercise as a key treatment, current exercise programs have only a modest effect, and engagement after 6 weeks is low. So consequently, around 50% of people will still experience significant episodes of neck pain despite being given exercises. So although exercise is the best we have to offer, it needs to be better. So we asked the question, how can we prescribe exercise to improve both engagement and its effectiveness? So we followed intervention mapping principles, which is an intervention development framework to outline a new approach to exercise prescription that would result in more engaging and effective exercise. At each stage, we combined data from patient workshops, expert consensus, existing literature, behavioural and psychological theories, and expertise amongst the study team to develop a new approach that was co-designed, evidence-based and theoretically informed. In the first step, we identified which outcomes exercise intends to improve. Then, to maximise engagement, we identified which exercise behaviours are required to self-manage neck pain and what barriers may prevent someone from engaging with those behaviours. Then we selected change techniques to overcome those barriers. To maximise the effectiveness, we initially identified the mechanisms by which exercise affects the outcomes from step 1. Then we selected the best exercises for each of those outcomes and planned how we could tailor those exercises to specifically target the relevant exercise mechanisms to optimise their effect. In step 4, we co-designed resources with patients and physiotherapists and co-designed a training programme for physios. And this is what we found. So firstly, I'll explain how we can prescribe exercise to make it more engaging. People need to engage with 4 key exercise behaviours, and they are performing neck exercise, independently adapting and progressing neck exercise, using neck exercise during a flare-up, and then commencing general exercise. We found 35 barriers that may prevent someone from engaging with these behaviours. And so, to overcome those barriers, we developed an exercise facilitation guide. And this guide can be used by clinicians in practice to support behaviour change. So physios initially will help patients set goals and improve their motivation to do exercise. Motivation is improved by enhancing the bio, psycho and social importance of neck exercise and its safety, by improving self-efficacy and engaging some social support. Next, action plans are set outlining where and when exercise will be performed, who can support and how, while encouraging some self-monitoring. Finally, maintenance of these behaviours is maintained through the use of progress reviews and supporting patients to become independent problem solvers. All of this is built upon active involvement with the patient in the process through good patient-centred communication and shared decision-making. To maximise the effectiveness, we developed a biopsychosocial exercise prescription framework that will guide a physiotherapist's exercise decision-making. Exercise programs should include a combination of exercises that normalise movement and improve the tolerance of the neck, with dosage described as an achievable challenge. These exercises are then tailored to target exercise mechanisms of neuromuscular function, pain self-efficacy, fear and catastrophising, night pain, cognitive control, or social support. The choice of which exercise mechanism to target is dependent on the overall desired outcome, which is determined by patient assessment and goals. The outcomes exercise intends to improve are pain, disability and function, sleep, mental well-being, or relationship impact, dependent on patient needs. This framework can be applied flexibly and can be retailored as a patient's needs change over time. So we developed a new approach to exercise prescription that uses a facilitation guide and an exercise prescription framework that aims to improve the effectiveness and engagement with exercise. We call the resultant exercise program from this approach the Epic Neck program. The Epic Neck program is individualised, evidence-informed and theoretically based. We intend to publish full details of this new approach, and we've already started establishing the feasibility and the acceptability to both patients and physiotherapists. Thank you for listening.
Thank you, Jonathan. You grab a seat and then I'll bring you back up at the end. Next up and closing out this session, we have got William Gregory, who's going to be talking to us about home BASMI, feasibility and tolerability of a remote consultation video delivered application for the bath and closing spondylitis metrology index.
Thanks, Ish. That's quite a long title, isn't it? Apologies. My name's Will. I'm a physiotherapist employed at consultant level by the rheumatology team at Salford Royal, which is just about 5 miles in that direction. So I had one of the shortest journeys. I've also got one of the shortest time slots. So this is a 5-minute rush through this project, representing the national group A Stretch, who are a collection of physiotherapists working in rehabilitation of axial spondyloarthritis. So What do we do for people living with axial spondyloarthritis? Well, it is World Arthritis Day today. I hope some of you have spotted that. And we know people living with an inflammatory arthritis need to be measured regularly to ensure we are maximising their treatments. Part of that is their movement scores. And in this condition, since 1994, we've had the BASMI. It is called the Bath Ankylosing Spondylitis Metrology Index because that was what we called the diagnosis at that time. These days, it's a broader spectrum of inflammatory back pain that's called axial spondyloarthritis. We were challenged when COVID-19 hit as how we could still do these vital movement scores for our patients when we were consulting online. And that led us to quickly get together and come up with a short-term solution, which I'm going to describe to you now. So the aim of this study was to assess the feasibility and tolerability of a simple, immediately available version of the BASMI for remote assessment and monitoring. We got together as a group of expert physiotherapists in this area, including lived experience input as well, and looked at those instructions from 30 years ago. We rephrased them to be appropriate for all of our patient group to read and follow at home and measure themselves. We sent this instruction sheet to 97 people living with axial spondyloarthritis who were due to attend a patient education event running in partnership with A-Stretch and the National Axial Spondyloarthritis Society. And during that online event, there were 2 breakout rooms where we invited these potential participants to come and measure themselves in this online forum, with us watching as physiotherapists, and then between us conclude how effective we thought this tool was. The feedback is extensive, and you're not going to be able to read this no matter how close to this screen you are, but if you put Home BASMI into your search engine and ignore the potential that they think you might be looking for a local DIY store, Home BASMI will give you all of that detail you can read at your leisure, but I'm just going to highlight the main points. So our physiotherapists are on the right, on the far side to me in the darker colour. Our patients who were measuring themselves are here in the paler colour, and their comments were, firstly, it's not too complex to follow. The pictures helped a lot. Lots of those lived experience experts said, what exactly is the tragus? And we suddenly realised that our description of how to measure perhaps needed a little more translation into more understandable language. We had lived experience participants saying they've trialled the measures over the week. However, they always get different numbers when they've got the tape measure out or the paper-based goniometer we sent to them. However, the nice feedback was from these lived experience group is it did make them think more about the measures that are done for them, and they were more engaged as they were measuring themselves or had a partner or a significant other measuring them at home, and it made them think about how they could gain more from their exercise routines. From a physiotherapist point of view, my colleagues said it was less nerve-wracking than they thought it might be. They were happy and confident by the end of the trial. They did note that female participants particularly were not keen to reveal their lumbar spine on camera, and hence finding L4 accurately was a challenge to do this measure. However, the conclusion was we do need several alternative ways to achieve roughly the same outcomes we get from measuring our patients. And there's a further follow-up study where we looked at why we do these measures and how important they are with exercise adherence and facilitating those behavioural change conversations. So in conclusion, this was a small sample size. The measurements couldn't really be compared to what we'd done previously in hospitals and physiotherapy departments because it was a self-measure. However, we had sufficient support to continue doing this where patients could not attend face-to-face. We are awaiting a digital assessment tool. There are some very big tech companies looking at ways to hold your phone and then measure yourself using the technology within that. But for now, we've got something that does work to a moderate degree to maintain that exercise conversation and keep measuring our patients to improve that ongoing therapeutic relationship. Thank you very much.
Thank you, William. So we've now got 15 minutes or so for questions. So any questions from the audience?
Hi, we've got one question from the online delegates. It's for Chinonso. I've been asked what the difference is between posture and postural hygiene.
Posture is just how people align themselves, whereas postural hygiene emphasizes specific good postures.
Thank you.
This is a question for John. Great to hear about your study, John. I was just thinking about your framework, and it looks really sensible and a great tool for people to use. But what's specific about it to neck pain, and could it just be used across a range of MSK conditions?
Yeah, thank you. I think that's a really good question. And so a lot of the data that was used to inform this from the existing literature, there's very little that was specific to neck pain. It was based on lots of chronic musculoskeletal diseases. The patient group that we had, although they all had neck pain, they also had a bit of a sore knee and a bit of a sore back and a bit of a sore shoulder. So my gut feeling is there's probably no difference between this and other chronic musculoskeletal diseases. And we think that's probably where we're going to go with it eventually, and doing some adaptation work to tweak it.
Any other questions from the audience? I think I've got one. And apologies, Suzanne, for asking, but kettles. What do you think that's all about? Why this focus on kettles and these what seem at first glance slightly odd recommendations around kettles? Where do you think that's come from?
Well, I mean, I put it to all of you, who's not talked about kettles with a patient before? I know I certainly have. Where's it come from? Where's a lot of what we recommend to our patients come from? I don't know, but it seems to be within the physio lexicon, doesn't it? We talk about lift a kettle, do this, and I suppose it's functional. You know, you can go and make yourself a cup of tea, you know, that sort of thing. So I wonder if that's where it's come from. But it's really interesting when you look at what kettles weigh. So I can't remember the exact details. My colleague in the audience did then go and have a look and start weighing, looking at how much the kettles weigh and how much does a litre of water weigh. And we realised that actually, well, you know, they didn't even equate to like a newborn baby and so forth. And we're like, oh, now we're saying you can't pick up a new baby and things like that when you're saying you can't lift up half a kettle of water. So I think we're coming from a position of being risk adverse and cautious and not really knowing. And so that seems sensible. It seemed like a good idea at the time. And we've stuck with it. So one of the questions that we did ask and I didn't present was what were the rationale for the restrictions? And most people, you know, over 70% or so said it was due to what the surgeons said, but 40% said, well, it's just historic. That's what we do. But I mean, there is literally one or two papers like that actually ever really looked at this. And it causes a lot of concern and apprehension amongst the patients and also the clinicians, be it the surgeons or the treating physios. And it is important because, you know, if you look at guidelines, if you look at who sees the patients immediately after surgery, it's not the doctors, it's not the surgeons who previously said, well, we need to say what it is because we know what the spine's like when we do the operation. But unless they're putting it in the op notes, the people that go and see that patient immediately after are the nurses and the physios. And then if you look at the guidelines, GERF guidelines for England, the first person that contacts the patient once they've discharged home or has contact is the physio. That's recommended at about 2 weeks post-op. So these are the questions that patients ask the physios. They ask other allied health professionals. So we need to know what the answers are and the rationales are, and we need to work with our surgeons to try and figure out whether we have to stick with the kettles or we can sort of progress a bit more from there.
Thank you. Any other questions at the front?
Yes, thank you to all of you. Question for Will. The home BASME. Do you see a role for that in providing timely intervention in disease progression and disease management?
Yeah, thanks for the question, Colin. I think it speaks into the move within rheumatology, certainly towards patient-initiated follow-up, where we're seeing the change from what might be 6-monthly serial review to rather reviews that are dictated by when the patient needs it. And I think we need to improve education with regards to that, because if we're allowing people living with long-term conditions to decide when they need to come and see us, we need to give them the tools to assist them to know when they need to make that call. So I think the ability to measure and do that at home could be a part of that package. As I say, it's probably going to be on your mobile phone long term, but with the home BASMI, we've got something that will just allow that. It does rely on movement restriction being an indication of disease flare, which isn't always the case. And the other element is we know that cardiovascular fitness is a big component of how we improve outcomes for our inflammatory arthritis patients. And obviously, the home BASMI is just how much they can move. So it's not really a correlate for perhaps the most important exercise outcome. But it's another tool within that PIFU, patient-initiated follow-up journey that we're on.
Thank you. Any further questions? I'm always particularly impressed by the rapid 5 presentations, because it's a lot of information in a very, very short space of time. But noting that we haven't got any more questions at the moment, I wondered, was there anything that you would have liked to have got into your presentations but you weren't able to because of time? Any of the pertinent things that you'd like to share, particularly our rapid 5 presenters?
So yes, I have. So we developed some resources for patients and physios. So we developed a workbook, we developed an app, and we developed a few other things. And if anyone ever wants to develop an app, if you think you need 12 months to do it, you need to double that now, because the barriers around IG and governance and IP are long and complex and frustrating, and no one ever has an answer, and then someone gets bored and just says, yes, fine, do what you want to do. So either don't develop an app, or if you are going to, increase your time frame and your budget that you think you're going to need for it.
Anything else you'd like to add?
I'll take an opportunity if you're offering, which is obviously that project looked at what we do with our inflammatory arthritis patients post-diagnosis, speaking to a room that may be more MSK than rheumatology. Obviously, how we get people diagnosed sooner is a massive role within that broader MSK workforce referring into rheumatology. So do look at ACT on ACTSPA as a good website to upskill the whole of our MSK community to get that diagnosis right down in the UK and get people seen sooner. That wasn't part of the project, but you did give me a minute. So.
No, that's fine. I'm share as much knowledge as we can. Was there anything else online or anyone more from the room? Great.
Hi, really enjoyed those. Thank you very much. This is a question for Jonathan, who might have been anticipating this one. Really helpful. Thank you. Thank you for the framework as well. Is there anything on hindsight that you do differently, or with the information that you've gathered, you think, oh, we should have explored this a little bit more? Or
Yeah. So if you'd asked me 5 or 6 months ago, I'd have said yes, I wouldn't have used intervention mapping. I'd used a different intervention development framework because it's quite long and thorough. But now, having come out the other side and having had chance to reflect, actually, the fact that it's so thorough has meant that I've been clear in justifying each of the decisions that I've made. But would I do anything differently if I was to do it again, or change anything? I think really trying to distill down even further what the really key behavioural change techniques are. The fidelity work that we've already started doing. So we're in feasibility testing now, and we're audio recording every single one of the appointments where this intervention is being delivered. And while physios think they are doing certain things, they are not. So while we think we are good communicators, actually there are a lot of flaws in what we're doing, and there are things that we could do a lot better. So, and I think part of that is a failing of or a limitation of the training that we've developed, that it maybe wasn't clear enough, or maybe there was too many things that we needed to upskill people in and try and distill them down a little bit more. I'll probably know a little bit more once we've finished our feasibility testing. We've had a chance to really look at our fidelity work, because that will really highlight where the gaps are and what we need to tweak for future rollout.
Question at the front.
Thank you. What fantastic presentations. Well done, everyone, in this session. Question for you, Chinonoso, about posture. You've done all of this reading and really looked into it in detail. What do you think is the role of posture in spine pain, personally?
Like I said, from the studies we've done previously, posture is not important for all patients. What I do know clearly is that there is no good posture for everyone. And that some of the postures we see as bad, it's not bad. People sit in slouch posture and they don't have any pain. And some people maintain very upright posture, but they have pain. So I think the important thing here is for us to not like put all patients in one box, to individualize our care. So find out what is aggravating for each patient. So for some patients, there's no postural involvement at all. For those that have postural involvement, what kind of posture is aggravating for that patient, and working with that patient to find a way to improve their symptoms. And another thing, again, that is important is what outcomes are we focusing on? So some of the studies we've done on looking at disability, predictors of disability, found that posture was absolutely not important at all. But when we looked at current symptoms, like present low back pain symptoms, we found that it was. But then the way it was important was different for different people. So for instance, you would expect that the bending, which was what was coming out from some of our qualitative studies before this one, bending forward was what was aggravating. But what we found from population-based observational studies was that actually kneeling and squatting, where you expect to see a straight spine, was actually more important in terms of predicting current back pain symptoms. So I think the focus here is not like we tend to have, okay, this is the back, show the patient the picture, you should keep your spine like this. I think we need to stop doing that and kind of maybe look more at the subjective assessment. What is it? What aggravates your symptoms? And does anything relieve it? And then using that to kind of inform the self-management for that patient.
Thank you. Is there any more? I think that's it. Well, I'd just like if we could all give all of our speakers a round of applause. They've done a great job presenting and answering the questions today. So we'll draw this session to a close. We have finished a little bit early, but just to let you know, lunch should be available from around about 12:30. Please do take time to have a look at the posters and around the exhibition hall, and we've also got our AGM, which is going to be in Exchange 1, starting at 12:30. Thank you, everybody.
Thank you.
Thank you all.
Thank you.